Good afternoon, Sir Danny and all the teaching team. Thank you for giving us an opportunity to present our case study today. First of all, we would like to introduce ourselves. My name is Octavianus Agung, and this is my friend.
My name is Ikra.
And we will present our case study. And this is for our case. So, 18 years old male with a history of poliomyelitis since age 4 presented with progressive right leg weakness, difficulty walking, and frequent falls. Examination showed quadriceps first grade, hamstring 4 grade, and ankle dorsiflexors 2 grade, causing knee buckling during stance and drop foot as well. A knee ankle foot orthosis or KFO was prescribed to improve stability and mobility. And the next one is identity patient. So the name is Mr. Agung, age 18 years old, the gender is male, occupation is college students, and weight and height is 60 kilogram and 170 centimeter. And for the medical diagnosis, he has post-polio syndrome on the right lower limb weakness. And the next one is subjective and objective. So for the chief complaint, he has difficulty walking, frequent falls, and toe dragging. For the past medical history, poliomyelitis at age 4, progressive weakness over last year, and daily activities use wheelchair for a long distance and using cane for the short walking. For the physical examination, this is the MMT for the muscle quadriceps. On the right affected is 1 out of 5 grade, hamstring is 4 out of 5 grade, and the ankle dorsiflexor is 2 out of 5 grade. On the left side is fully 5 grade. And the next one is ROM or range of motion. For the knee flexion, on the left side is 135 degree and the right is 133 degree. And the knee extension is 0 degree and the right side is 0 degree as well. And for the ankle plantar flexion is 49 degree on the left side, and for the right side is 48 degree. Ankle dorsiflexion is 20 degree, and on the right side, which is the affected, is only 10 degree because he has only 2 grade dorsiflexor. And for the inversion is 35 degree and the right is 35 degree too, and inversion 20 degree and the right side is 20 degree too. And for the knee range of motion, he has no contractor, which is good, and for the balance is decreased and fall risk during walking. Okay, the next one is gait assessment, which will be presented by my friends Ikra.
Okay, thank you, Agung. Gait assessment, hip hiking and triangular compensation, right knee buckling during stance pace, walking speed, slow, use cane to encourage stability. Functional examination, hip joint function normally, no limitation. Knee joint passive from range of motion, intact active extension, pivot, instability and buckling. And ankle joint, dorsiflexor weakness, foot drop, and overall independent walking possible but unstable gait with frequent falls. And the next orthotic goals: stabilize knee during stand pace, prevent falls and improve safety, enhance walking efficiency, and prevent drop foot. The next presentation will be by Agung.
Okay, thank you Ikra for the presentation. So the next one is prescription. So for our design, we will give the patient molded CAFO right lower limb. Because molded CAFO has bigger area, so it will less pressure to the patient and it will result in more comfortable. And for the knee axis, we will give drop lock. Why? Because patient has grade 1 quadriceps muscle and drop lock able to provide stability and prevent knee buckling, because drop lock will set in the knee extension. And for the ankle joint, we will give EVO posterior left spring PLS. So EVO PLS set in 5-degree dorsiflexion, and it's able to prevent drop foot during walking, so patient feel more comfortable during walking. And the next one is design. So this is our design molded CAFO. For the material, we will use polypropylene copolymer. Why? Because it's durable and impact strength. And for the other material, we will use a stainless steel sidebar and leather tights and calf cuffs. And for the components, knee joint is drop lock, locked during stance, unlocked, optional for sitting. And for the ankle joint is PLS, posterior left spring. EVO for swing pace dorsiflexion assistance. And the next one is manufacturing techniques. So the first one, we will casting the patient, negative casting with knee in slightly flexion, and after that we will modify the positive cast, which is rectification, and after that we will go to the draping or thermoforming plastic material, and we will heading to the assemble with knee and ankle joints. And after all the process is going good, we will go to the finishing and fitting to the patient and alignment check. Alright. Well, the next presentation is follow-up will be presented by my friends Ikra.
Okay, follow up for the patient. Start from 1 until 2 weeks. Inspect skin and comfort. Guide training with CAFO. Adjust if needed. And medium term 1 until 3 months. And monitor guide stair climbing, standing endurance, and physiotherapy to maintain muscle strength. Long term 6 months. Improve independence and safety. Maintenance of orthosis, straps and joints, and evaluated for adjustment or replacement. Okay, patient education, instruction on donning, doffing, and daily care of CAFO, skin care to prevent pressure sores, and importance of regular follow-up, encourage physiotherapy and daily activity. Seek immediate help if pain, skin breakdown, or orthosis malfunction. Okay, the next presentation will be by Agung.
Alright. Thank you, Ikra, for the presentation. So this is our references. Before we go to the last part, I will give the conclusion regarding our presentation. So the conclusion is the case of an 18-year-old male with post-poliomyelitis demonstrates that although passive joint motion remains preserved, severe quadriceps weakness and dorsiflexor involvement limit active function, leading to the knee buckling and toe drag. A combined orthotic approach using a CAFO with a lock knee joint, drop lock, and a posterior left spring EVO PLS provides the necessary mechanical stability and dynamic assistance, improving gait safety, reducing fall risk, and promoting greater independence in daily mobility, and it will meet expectation patient. So the patient will not feel false anymore, and he will more comfortable during walking. All right, I think that's all from us. We will say thank you